It's a great pleasure to be here. It's my great honor the first time I'm addressing an audience in India. I'm from the company Sigma Jones. We are a relatively new company, a joint venture of an award-winning AV integrator, Sigma AV IT from Bangalore, who have offices across India, and Jones AV, a medical integrator specialist from the UK. And we have teamed up in 2017 to develop specialist solutions looking at the Indian market, looking at operating theatre requirements, the standard of operating theatres, and delivering improvements that will help surgeons in treatment for patients, but also help improve the bottom line for hospitals itself. Technology investment should also bring improvements for the patient and, of course, a return on investment. Right, so what's an integrated theatre? You probably all have come across integrated theatres in various forms, where you integrate patients' data, audio, video images produced by different devices in the operating theatre, such as C-arms, endoscopes, and also telemedicine. So the systems help not just the treatment of the patient in the operating theatre, but also for training of new surgeons and remote treatments. Now, a lot of systems have been sold by medical manufacturers as an out-of-the-box solution, which kind of everyone applies the same. So we look at things very differently. We look at things from a perspective of the team in the operating theatre. What is relevant to the people where they work? How can workflows be improved? That the relevant information is displayed at the right time, at the right moment. So knowledge, images, reference materials can be accessed when it's necessary. This, of course, then allows all the actors in the operating theatre, rather than to react, it allows them to act and be proactive. Proactive teams in operating theatres work better, they work better together, they work more dynamic, it's a better working environment. It takes out stress situations, especially in emergency cases. People see what's happening. It's not necessary to shout at people, situations that often occur in operating theatres, because people can't see what's happening. People get tense, emotions run high. Another area where digital integrations really help in operating theatres is the digital patient file, attaching images to a patient file. Obviously allows you for better care and aftercare. You can review and assess operational techniques after the operation. But also it helps in cases of litigation. So if you need to refer or review to an operation, you can refer to video sections or images quite easily and protect yourself from this. So overall, the key element in there is, of course, not just the streamlining of processes, it's the improvement of the working environment, and that's also the improvement for patient outcomes. So how do you get the most of these systems? I've touched a few elements of this before. We believe it's in customizing the design, and customizing the design by the specialty. You have many different specialties, from orthopedics to neurology. There's different requirements in the OT, different technology that's used in the OT, and different workflows. So each operating theatre can be bespoke in a way. So on the other hand, talking to the operational team prior to building operating theatres saves lots of money. You only need to integrate what is really needed for that team. Don't buy an out of the box where everything comes the same. You can really make savings, especially I've seen many projects where hospitals and operating theatres get built without referring to the needs of the specialists, and once the systems are built, the specialists actually come into the operating theatres and find the working environment is entirely not right for them. And I've a very extreme case in a large hospital in Norway. The chief surgeon went into the operating theatre of the day of opening and said he can't work in this theatre. This theatre got closed the same day. It was one of 50 in the hospital. It had to be closed and it had to be refurbished at a cost of 1.5 million euro. So it's things that can be avoided with proper planning and actually consulting the teams, the people that work there, and respecting their needs. Of course, another element that comes into it is a buzzword in Europe, I believe in India as well, is future-proofing. What technology do I implement today that I can still use it in 10 years, 15 years? Capital projects in hospital are expensive. And to really get a return on your investment, it needs to be future-proof, it needs to last a long time. Technological development currently gets faster and faster. So we have seen in imaging the dawn of HD, now getting replaced by 4K. In Japan already the first 8K endoscopes are in use. 8K technology becomes available for your living room, TVs, cameras. In Japan also broadcasts of major sports events already happen in 8K. Now, there's many advantages in being future-proof. There's cost advantages. Once you employ the architecture, you can upgrade to new technologies on the same backbone. But also there's advantages in treatment for patients. If a surgeon has a great picture, he can see more details, he can make faster decisions, he can make a better diagnosis. In training, if I relay a more high quality image to surgeons, surgical students often don't know what they look at. The better image quality of what they can see, the easier it is for them to identify structures, to see what they need to look at. So having the technology, a backbone today, allows to build upon and be up to date in the future. So we have heard before about standardization. Then there's big drives for standardization in healthcare at the moment across the board. And there's different approaches to this. There's the standard big data approach, where people say, we must connect all devices and we must collect all the data. But what am I doing with the data? So if I don't first build an environment where I can do meaningful work, where the work actually is efficient, what do I do with just a lot of data? I can have as much data as I want. If I don't know how to extract value from the data, it's meaningless. So the standard big data-driven production method is to look at everything as the same. Often, we have emergency cases, cases vary. Surgeons come from different trainings, from different universities, different backgrounds, we heard earlier. So there's an element to say, we have to remove the human factor. But to a great extent, it's not about removing the human factor, it's about empowering the humans that are there. It's giving them equal methods for working and also helping them to give better treatment. I've recently had a project in Germany at a sports clinic where a new managing director came in. He came from the car industry and he set out that in manufacturing in the car industry, everything is standardized, every workflow, every process. And he said, why can't it happen in healthcare? We got all the technology, why can't we deploy the technology so we can standardize every operation, every surgeon has to do the same turn. It's almost, you look at it as if turning a screw. Everyone turns the screw the same way. And he went ahead and he spent a lot of money getting some of the best experts from Germany and the UK together to look at this manufacturing improvements. And he came up with a solution which on paper sounded very good. However, the day he presented his approach to the surgeons and his data measurement of their performance and their drive to actually rate their performance on time in terms of cost, within 2 days he lost his job because all the surgeons said it's either us or him, but not this way. So for us, a big learning out of this project as well was, of course, so how do we do it? So there's from the car industry, another example. In the 1970s and early 80s, Volvo in Sweden was one of the first car companies that moved away from production line production. So they stopped having everyone on a production line. It strains people, repetitive processes, same job, people get very bored. So they looked at improving it. They reorganized the people on the production lines into teams, and they asked the teams for input. They asked the teams for positive input. They achieved incredible performance improvements by asking the people that are actually doing the work, rather than going, getting a consultant that streamlines the production process on paper. The team itself brings valuable input. Again, Volvo recently has done an exercise in their plants in Sweden and in Dublin, where they looked at energy savings. Rather than consulting the big data to save energy, they asked their teams on the floor, where can we go? They sent them an energy hunt to find options how to save energy. It's an easy example, but they came back within a week, very easy options of like switch the machine off, that doesn't need to be on. They made savings of $538,000 in one plant. And it didn't cost them anything. They didn't have to invest in big technology, they asked the staff. So, so looking at integrations in the operating theatres, it's about helping the team, taking in what the team in the operating theatre needs, to proactively design around them, to reduce the stress and strain. I'm sure our surgeons in here know how much strain long operations are on your back. When you do endoscopy, you have to twist yourself, you stand in awkward positions. If you have an operating theatre that's more ergonomically designed, you have less stress and strain on yourself. Work becomes easier. If people, your assistants, have images when and where they need them, it becomes easier to work because things are ready and prepared when you need them. Overall, we've had in Royal Papworth, one of the UK's newest cardiology centres, people saying, it's great, we don't have to look over the shoulder of the surgeon no more to know what's going on. We can see what's happening at every time. It's small things that really help people to work more efficient, to bring things up. In hospitals in Belgium, we had bottom line improvements through a simple point to better imaging. People can assess, treat better, reduce errors. But also, if you look at shorter operations, you use less consumables. It's in orthopedics, examples are you use less fluids to drain the operation area, or it's you use less tools if you use endoscopy. So there's a lot of positives around that if you focus on the team and empowering the team rather than just focusing on the technology. technology is surely there, and technology helps, but technology should always supplement and support. So, again, I've probably haven't read much of my presentation and talk more freely. But if you look at the outcomes I listed here, so in terms of workflow, in terms of error, there is a lot to be said for the technology. And one area that has been touched on a lot earlier in the first keynote was training and remote medicine. Better training through having systems in operating theatres that allow more people to be trained at the same time. I can relay video from the OT rather than having 5 people standing next to the surgeon. I can train a lecture theatre with 200, 500. We've done big lecture theatres in Norway with 500 people attending operations on a daily basis. They can see from the surgeon's view with a head cam, they can see the endoscopic view, they have access to PACS with his images, at the same time to a knowledge base and the support from lecturers that can comment on the procedure. So training is an integral element of this, and I wouldn't say a side effect of a good integrated system, but it's surely something that you should make use of. Another element, of course, is the referral, where surgeons can, during operations, refer to other surgeons for second opinion. If you have multiple operating theatres, a surgeon comes across a difficult case, you can refer to each other to solve the case without having to unscrap, descrap. But also, it helps for remote surgery. Specialists can help in operations. At the same time, you can, of course, in areas such as dermatology, you can do remote assessments very easily. We have in Norway, which is a very sparsely populated country, done tests in remote villages in 2009 already about treating dermatology in the center hospital that was over 300 kilometers away. At the time, as you can imagine, 2009, mobile phones didn't have cameras, and the networks weren't very efficient. So it was difficult having to use fiber optic lines to deliver this service, whereas the technology has advanced so much now that simple things like this can be done with mobile phones, and they can be integrated back into a well-integrated system in the hospital, allowing physicians and doctors to do assessments, whilst you have nurses and support staff in remote locations, making medicine treatment more efficient, and through more efficiency, you increase the bottom line. Thank you so much.